we need to consider the consumer right groups. And then why this theme today, I think, is a culmination of various research and is from the reality of the occupational health and safety of health workers, that health workers really face numerous challenges and risks. So some of them are healthcare associated infections, and they are real violence. I'm sure you've also read stories of health workers being harmed or beaten up in their places of work. Then there is also the stigma and the psychological harm, or probably the kind of counter-transference when you're dealing with very sick patients. So we really need to think about that. And then the emotional disturbances. And in our context, we know the delays of a lot of motivation and all that, the work environment. So these all contribute to harming the health workers. And we know when you work in stressful environment, you cannot give your best. So we really need to protect the health workers if we hope for them to give us their best and reduce harm to the patient. And the new challenge, like the COVID-19, that's the new reality. And I think you are reading stories every day about the increased risks to the health workers. And we've lost quite a number of health workers to this pandemic because of the exposure in their work environment. And you see, these is a direct consequence of the work environment, and probably sometimes there are issues of substandard personal protective equipment that are coming up. So really health workers really need to be considered at the core of patient safety. So the overall objective I've already mentioned, but some of them in emphasis again is raising awareness. And then we want to engage multiple stakeholders. We can't do this alone as the Ministry of Health. And I'm glad there are already quite a number of stakeholders who have joined this team in supporting the patient safety. And then we also need to implement sustainable actions, like beyond the support that these partners are offering. What is the sustainability of this? We don't want to end some of these activities when probably the funding cycle of some of the partners ends. And the other thing also, to provide due recognition to health workers. We want to move beyond the Wednesday clapping. And I think it also stopped at some point. Like health workers, tunapigiwa makofi, and probably some are gaining more benefits. So we need to move beyond the lip service that we offer to our health care workers who are really dedicated to, and they are really the frontline health workers. And finally, I want to reiterate that the Ministry of Health is committed to providing the highest attainable standard of health. And I think this cannot be offered without considering the health workers who are the frontliners. So we thank the Division of Patient Safety, were very well represented. I can see all of them in their office following closely. They've been doing a very good work. So we also support them. They're working with all the other divisions and the other departments within the ministry to give their core mandate in terms of patient safety, antimicrobial resistance, just to mention a few of the tasks they do. And finally, we have to join the rallying call, like we really need to keep our health workers safe for us to have safety of our patients. So at the end of the day, they really need to give us huduma bora, sio bora huduma. If we don't take care of the occupational risks, the health hazards, emotional needs, and even the economic needs, we might not achieve this. So the theme for today is quite critical, and I wish everyone fruitful deliberations. And at the end of the day, we'll compare notes and probably do an audit of beyond from last year to this year. What have we achieved and how do we move as we continue commemorating this day and giving patient services in our facilities? So thank you, Dr. Irungu. Those are my many remarks.
Thank you so much, Dr. Oyoko. We are glad to have you. I think we'll go to the next presenter. We'll have remarks from our partners who have really supported from the inception, preparation, and actually to this day, make sure that this day has come to pass. And we'll start with Dr. Lydia Okutoi from Kenyatta National Hospital, who has been among the key stakeholders in as far as preparation for this day is concerned. So welcome, Dr. Okutoi.
Good morning. I'm so glad to be here on this World Patient Safety Day. And thank you very much, Irungu, and the Patient Safety Unit at Ministry of Health. We are indeed honored that as a country, we are doing this for the second time, and this is the second World Patient Safety Day. This is indeed important to take time to see where we are. So safety being an important dimension of quality, it comes at a point that among the three pillars of quality of care, which is care that is effective and care that is person-centered. Now, having care that is safe is actually the premise of everything. It is the beginning of ensuring that there's no harm to Wanjiku when they come to care. But as we know that patients still experience harm when they seek healthcare, amidst the advances that we have in our technology and our medicines and our processes, still harm happens. And so it means that we have a lot of space and opportunities to improve and address this. And we thank such efforts that are bringing patient safety to great awareness. On such a day, the idea is to increase public awareness and to enhance the global understanding towards working together. That is why Amos mentioned the multi-sectorial approach and various partners and various professionals, because we know that healthcare is provided in a complex environment. We have very few linear associations. A lot of health is provided by multiple players using equipments and spaces that are controlled by different people. And so safety is a debate for all of us. So just a bit of what WHO had said earlier, that we move from seeing person-centered care to, from patient-centered care to person-centered care, meaning that the person, that is the staff, and the patient are in the center of ensuring quality care. And so the theme of this year being that healthcare workers being safe ensures that patients are safe is very important, because it brings that person to life. And especially in this era of COVID, the healthcare worker has been at the forefront, and so has suffered just like the rest of the community, but beyond what the risk involved in the community. For us, it is an occupational risk as we get into these spaces. And so this day, focusing on the prioritizing the staff is an important day for us. At Kenyatta National Hospital, we endeavor that care that we give will be safe. In our mission and vision, it is clearly stipulated that this is a big prerequisite of quality. And so we monitor safety and we report this systematically. We do this up to the board level. And we have various levels of performance indicators that include safety. And we aspire to learn to measure this in a valid way. And there's opportunity then for research concerning patient safety. And we join these efforts and share the lessons, and also learn from when mistakes happen, because we know that human is error. So in healthcare, creating strengthening the systems, it requires that we are open to learn. So as we take stock on the efforts, especially made for safer care through health worker safety, we are looking at optimizing the environment so that we are having equipments and processes that align. But when a healthcare worker comes to provide care, there are no system issues, communication, leadership, or team dynamics that bring a challenge. So as leaderships, I think we need to commit ourselves to ensure that that environment is sustained and maintained at the front line, where the patient receives care, to ensure that is coming every day. When they come to work, and when it comes to our patients, very few are outliers that may have such intention, but no healthcare worker comes to harm patients. So when harm happens, we try to ensure that we understand what are these issues that surrounded that event, and how can we optimize human factors to ensure that the healthcare worker can be able to deliver, and beyond delivery of care, that they too are safe. So during this COVID era, let me mention a few things that have happened in the country, and even as KNH at the forefront. We know that as a country, there's been provision of the PPEs. I think we continue saying that that is a very important step of ensuring that there's protection for these healthcare workers. They offer care between the healthcare workers, amongst them, and then also to the patient or to the environment, that we're ensuring safety and ensuring psychological safety, in that we've been at KNH having opportunities for debriefs, and those who need psychological care, that is availed. And in the case of exposure, then also there's a process that we support the healthcare worker through it. And we have been learning lessons. Some things have happened in a good way. Others have not been that perfect. And as a hospital, I can say that the management has dared to learn and to improve and to have a coordination center for COVID the team, the COVID response team, has been able to do a great job in ensuring that there's timely and accurate information to staff, so that there is little anxiety, and where there's no guidance, that has also been provided in terms of SOPs that are updated in view of the COVID pandemic. Then I also mentioned that there's the OSHE, and approaching the ergonomics and the physical spaces and the equipments in terms of how that can optimize the human factors for safe provision of care. KNH is mandated by the Ministry of Health also to have such committees, and for which they are active and vibrant and trying to optimize the spaces for that. Then also the employee protection units that support our healthcare workers in case they need support. So other opportunities that we need to explore is continuous strengthening reporting of occupational safety events, and then also just on matters of knowing a surveillance system. Did anybody get TB from exposure in the ward? So to some extent, we're doing a great job in monitoring like PEP, those who've been exposed with needle stick, and also other aspects of monitoring need to be strengthened. And that will be a hallmark of having healthcare worker events and incidents being documented and addressed at a system level. So also another thing that Amos mentioned was about violence to healthcare workers. I think as a country, as a hospital, we need to be bold and put a statement that we will not tolerate any violence to a healthcare worker. It seems obvious, but when we walk to the airports, we see it is written. If you walk to Heathrow, it will be very clear that you should not be violent to the police officer. Action will be taken against you. So as much as healthcare workers come to work in unfortunate events, at times they get physical harm. And I think as a country, we need to put that statement clear that that will not be tolerated. Other approaches that I think we can take, and we have taken to a small extent, but we can scale this up as a hospital and as a nation, is just to ensure that there is joy at work, to regularly celebrate the small successes that happen. That ensures ecological safety. To have teams that are functional, that work and are able to meet even with little familiarity and deliver a task and be happy about it. And so all this is about leadership. As an institution, leadership is a key pillar to how we run business. And so there is always effort for empowerment of the staff towards doing this. But in health, we deal with such serious matters that once in a while we forget that if we don't ensure that the healthcare worker is happy to come to work and happy to work in that environment, then we may not be doing, we may not be optimizing the emotional energy to offer care. And so as we celebrate this day, let us, in our small spaces, look at opportunities we can have to have this healthcare worker be a happy and optimized healthcare worker. We're using all their resources for the purpose of ensuring that when we take stock next year, we will say we have moved a step ahead. And so thank you very much for having KNH represent partners, and then also just in us having an opportunity to show the steps we are taking and the growth we desire to continue having. Thank you very much, Irungu and Amos.
Thank you, Dr. Lydia Oktori, for a speech that you've just given, and thank you for showing us the progress and updating us on what KNH is doing right and areas of improvement. Our next speaker is also one of our partners from USAID MTAPS, Dr. Ndinda Kusu. Dr. Ndinda serves as the Country Project Director for USAID MTAPS. MTAPS stands for Medicines, Technologies, and Pharmaceutical Services Program. MTAPS aims to help low and middle income countries strengthen their pharmaceutical systems. And this is the right place to have a conversation with Dr. Ndinda Kusu. So Dr. Ndinda Kusu, karibu sana. Hello, Dr. Ndinda Kusu.
Thank you very much, Dr. Kalondu, for the introduction, and also for inviting me to be one of the panelists. Indeed, patient safety is so dear to me and close to us as an organization and as a nation. It's a timely conversation in the midst of this COVID-19 pandemic. And I'm also excited that we have managed, besides the challenges of the pandemic, to actually celebrate this in a big way and honor our healthcare workers and promote both patient safety and health worker safety. Just in line with the theme, really for us to ensure we have patient safety, we must ensure our health workers are safe. And we should really speak up for health worker safety, while recognizing that there have been challenges over the years, in that as much as we've had a lot of resources going into strengthening health systems, we still see cases of health worker, exposures. We see patient safety being compromised. We see health workers getting infections from their institutions. We see also patients getting hospital-acquired infections, or even infections that are, acquired because of compromise of either the systems, the institution, or also because of the care that is being provided being suboptimal, or because we have, products, protective equipment that may be of questionable quality and safety. It's hard to separate quality and safety, and it's also hard to say as a nation that we can achieve universal health coverage without paying attention really to safety issues, to safety of our patients, to the safety of the care we provide, and to the safety of our healthcare workers. As a USAID funded project, Medicine, Technologies, and Pharmaceutical Services program has been in this space. We are in a number of countries, and we have been in Kenya really working collaboratively under the leadership of the Ministry of Health and other partners to support patient safety outside even this day. We have support from Global Health Security Agenda to support containment of antimicrobial resistance. And within that support, we've been able, to put resources to contain antimicrobial resistance with a focus on multisectoral coordination, with a focus on promoting optimal use of antimicrobials through antimicrobial stewardship. And we've also been supporting in a big way infection prevention and control. Working on these 3 areas, we really are working at the national level with the relevant division of the patient safety and health worker safety. But beyond that, we are also tackling the support for IPC, AMR, AMS through the lens of, the One Health agenda. At the national level, we really are supporting the development of the relevant guidelines, tools, policies to ensure that we promote patient safety, to ensure that we have good infection prevention control practices and other AMR-related focus. When it comes to the counties, through the Global Health Security Agenda work, we've been focusing on 2 counties, Kisumu and Nyeri, and hope to extend to 1 or more counties if resources allow through USAID support. And within the counties, again, is really to ensure what comes out of the national level is implemented at the county level and in our focus health facilities. We are in 18 health facilities in both Nyeri and Kisumu, and we are also working here at the national level to support antimicrobial stewardship in Gertrude's Hospital and also in KNH. Happy again to partner with all these institutions. MTAPS during this pandemic has been very instrumental in collaborating with MOH and other partners to support, the country's preparedness and containment of COVID-19. And right from mid-March, we again really stepped up to support the country in supporting development of the key IPC COVID-19 training packages, job aids, and we were able to build capacity of both national level trainers, county level trainers, and also trickle down to the health facilities. And through that support, we've also had other partners really take up the packages that we had contributed to development at the national level and implement them in other counties, other facilities far and wide, targeting public, faith-based, and the private sectors. Through our IPC work, we are employing a continuous quality improvement approach in our focus health facilities to ensure that, we promote safety of patients and health workers. And how can you really promote safety of health workers without building both institutional and human resource capacities? We cannot have safe patients without having safe health workers. And so we are striving and continue to strive every day in the work we are doing through AMR, through COVID-19 and any other work through our larger pharmaceutical system strengthening agenda to ensure that we build capacities of the institutions we are working with, of the people we are working with, to ensure that we promote safety. Outside Kenya, we also have some work we are doing within the region with the East African community and the IGAD region, focusing on regulatory system strengthening and pharmacovigilance, with a goal again of promoting patient safety by ensuring that we monitor and ensure that we have safe medicines, whether they are new or existing, and support that for existing medicines, health technologies, and also support that strong system for even any other, new medicines and technologies that may be introduced, talking about medicines, talking about vaccines and others. So in a nutshell is really to say, thank you for the opportunity to congratulate the country and also recognize the strong partnerships that we are having as a country under the leadership of the Ministry of Health and the other partners, donors, private sector, that again have rallied their efforts to support this country to promote patient and health worker safety in the country. And thank you, and I look forward to the continued engagement as a person being very passionate about patient safety, and also as an organization to ensure that we push this patient and health worker safety forward. Thank you, and over.
Thank you, Dr. Ndinda Kusu, for your remarks, and we are glad about the work that you're doing in Kenya and outside Kenya. We appreciate all the efforts that you put into place, and we look forward to working more with you as KNH. Our next partner is from Farm Access. Dr. Kennedy Okongo is the Medical Credit Fund Director for East Africa Group, Farm Access Group. Medical Credit Fund is, it works with partnering with private facilities and providing access to care, affordable finance and support to improve the quality of care that they deliver. So Dr. Kennedy Okongo, karibu sana.
Thank you, Linda. Good morning, everyone. Unfortunately, you will not get to see my face as I've just been called into this. I was actually on the road. I was just parked on the roadside. On behalf of the Farm Access Group, that is SafeCare, Medical Credit Fund, and Health Management Systems, I'd like to take this opportunity to thank the Ministry of Health for being in the forefront for ensuring that patient safety is a priority. Looking at the theme this year, which is health worker safety, a priority for patient safety, it has actually come at the right time, say in the middle of a pandemic, which has actually unmasked a lot of significant gaps between what is needed to run an effective healthcare organization vis-a-vis what we currently have in place. Key pillars being access to healthcare financing, trained, competent human resource professionals, effective high-quality supply chain, enabling policies addressing the health quality agenda, decreased barriers to technology solutions, and enabling environments to support innovative public-private partnerships. The reality on the ground is that healthcare has been significantly overlooked, and budgetary allocations are not adequate or do not reach the last mile to effectively impact service delivery. Our human resources are working diligently with what they have to provide care, but resources and tools are lacking, and effective plans to continuously and professionally develop and upskill, in addition to adequately remunerate and recognize the contribution to enhance our economies, are drawn out work in progress that needs urgent attention. Unfortunately, as we celebrate this today, it's happening when a majority of our healthcare workers are going on strike due to so many other reasons. Our county governments are looking at actually closing provision of services at a very critical time, meaning that we are putting our frontline healthcare workers at the center of it all. There is no better time than now to actually recognize the value and contribution towards the tireless dedication, both nationally and globally. This day is a culmination of a vast multidisciplinary team that stems from our donors, doctors, nurses, lab technologists, pharmacists, and allied health team members to our housekeeper security and the broader support team. At Farm Access, we try to ensure that patient safety that implies on quality and standards of care meet regulatory requirements at the bare minimum, but also challenge systems towards excellence by further instituting national or international certification and accreditation programs such as SafeCare, JCI, and ISO, just to strengthen organization systems and processes and to demonstrate the continuous improvement journey towards excellence. Patient safety resonates well with the acronym STEEP, that is safe, timely, effective, efficient, equitable person-centered care. This is easily translated as reducing harm, applying evidence-based practice, reducing delays and waste, and placing patient at the center, irrespective of the socio-economic status. This resonates with the 3 pillars that link to the universal healthcare coverage, which you all know currently is one of the key pillars of our current government. In conclusion, it is each of our responsibility to speak up for the patient safety. This starts with the policymakers and leaders making sure that we have the right policies in place to effect an enabling environment that upholds overall safety in our entire health ecosystem. We all at one point are recipients of healthcare, and therefore, as we prioritize patient safety, we must make sure that we build a system that will work for all of us. It starts at the national level, to the county level, to the facility level, and then trickles down to the consumers of healthcare advocating for safety. This highlights the need for patient education to ensure that consumers of healthcare are knowledgeable and can speak up for themselves and demand the care that they deserve. If we are able to address this as a nation, then we'll be in a position to say that, yes, we are making steps to ensure that patient safety is actually addressed. Thank you so much, and over to you, Rhoda.
Thank you very much, Dr. Kennedy Mpando, and we apologize for the ambush, but thank you very much for representing Farm Access, who've been our partners and we've walked the journey with them. Our next presenter is Dr. Daniel Kimani from Center for Disease Prevention and Control, CDC. Dr. Daniel Kimani is a public health specialist, widely experienced. He's dealt with blood safety, injection safety, waste management, TB and HIV programs, among many other health programs. Today he's going to talk to us about injection safety in relation to health worker safety. So Dr. Daniel Kimani, karibu sana.
I want to so thank you very much. I've put my face partially because I can see I have many clones with the same name. I'll be presenting on needle stick injury as a part of healthcare worker safety. Would you confirm that I need to get the rights to share? I wanted to have a presentation.
Yes, you can share your screen, Dr. Kimani.
Okay. Kindly confirm that you can see my full screen.
Yes, we can.
Okay, so thank you very much. I want to focus on needle stick injury because this is a pertinent issue in terms of healthcare worker safety, and is actually a very prevalent thing. I'll provide a context and background, provide some results from an assessment we did and published in 2016 related to needle stick injuries in the country, and try to say what we are doing as CDC. And thank you very much for giving us this opportunity, as well as CDC and the President's Emergency Plan for AIDS Relief, PEPFAR, that supports a lot of infection control work. Let us start by reviewing the global and national goals in terms of health. The Sustainable Development Goal 3 talks about ensuring healthy lives and promoting well-being for all. And the target 3.8 talks about achieving universal health coverage, which as a country we are also committed to. The UHC has 4 pillars. One is equitable access, both in terms of geographic coverage as well as range of service, quality of health services, affordability, and economic protection. Now, what is the role of the healthcare worker in UHC? I think I need to state that for you to provide quality health services, you need to be safe and healthy as a healthcare worker yourself. Secondly, I looked at the Kenya Health Workforce Report of 2015. And this report did look at reasons for attrition, why healthcare workers were leaving work. And analyzing 4,431 healthcare workers' reasons, 50% of those were due to illness or death. Sometimes we never stop to ask ourselves, why are healthcare workers ill or why are they dying? And I know sometimes we are shy to associate some of the illnesses to the workplace that we work. But at the same time, to state that in terms of the healthcare worker numbers, we are far below the recommendations from WHO in terms of achieving the SDGs. For example, in total, WHO recommends about 45 healthcare workers per 10,000 population, and we have only reached less than 14. This is worse for doctors and also still below for nurses and other healthcare workers. What this means is that when one healthcare worker is absent from work due to an occupational illness or otherwise, there's a big impact on the whole service delivery. Now, coming down to the needle stick injuries, and I know we have all experienced this. We remember when you looked at that finger and realized you are pricked. It's a major problem. Nationally, it is estimated that some studies indicate that 15 to 25% of healthcare workers experience a needle stick injury annually. I did see a small study from KNH presented 2 years ago that did show about 40%, yet they are very low reporting rates. Most people, once they have been pricked, they actually keep quiet. This is in the context of where we have very high HIV prevalence as well as hepatitis B prevalence, and a situation where hepatitis B vaccination is not well uptaken. So to look at the situation, we did carry out a study in that 5 facilities across 18 counties, and these included 2 national referral, teaching and referral hospitals, 17 county referral hospitals, 24 sub-county, and 10 health centers. So really a spectrum of all health facilities, and you can see from the map that this was across the country. We abstracted data from what is called the PEP register or any other records that was available, and only 35 of the 53 initially sampled facilities had any form of some records, and 60% was using some rudimentary record like a black book, and therefore most of the records were incomplete. In the 4-year period under review, within these 35 facilities, we were able to analyze 1,665 exposures. Most of these were needle stick injuries, but 10% were mucosal splashes. Needle stick injuries here include other sharp injuries, for example, from blades and lancets. In terms of the actual findings, we found that in terms of healthcare worker, as we expect, nurses are the majority in health facilities. But in terms of the needle sticks were more among the doctors, followed by clinical officers and lab workers. And again, this brings out the issue of frontline healthcare workers that are carrying out invasive procedures being at the highest risk of exposure. Looking at where and what was causing the needle stick injuries, most of the injuries occurred within the medical wards, surgical wards, the theater because of the procedures there, the maternity unit, as well as the dental unit. Those were the top 5 places that the injuries were occurring. Looking at the procedures, giving injections, and this is because there are so many injections given in hospital, both IM subcute was the leading cause, followed by IV access or getting a cannula in or fixing a line or all those procedures related to that. And blood collection was the third leading cause of needle stick injuries. I think we have all seen these kind of pictures, very risky procedures where one is likely to prick themselves and push some blood inside. We've seen overfilled sharps container, and this can fall on you if you are wearing an open shoe and you get a prick. You've seen needles left on the bedside, procedures that are risky and blood coming out. But also when you look at the cannulations that we have, sometimes there is all this kind of blood staining, which tells you that there was a possibility of this blood contaminating somebody, and if you have a broken skin, then you are at risk of any infection. Now, when the healthcare workers experience a needle stick injuries, there is the immediate reactions that they get. Of course, there is the panic, there is the anxiety, the fear, the depression, you are thinking of possible infection, and a culture of silence. This article here in one of the journals actually did talk about needle stick injuries in the National Health Service in the UK, and they also describes a culture of silence. A lot of people just keep quiet about it. But afterwards, there are issues related to reporting. Will you be deemed as incompetent? And that's why you got a needle stick injury. There's the stigma, someone is taking PEP, you are struggling with the side effects. At least now we have safer drugs with fewer side effects, but previously that was not the case. Therefore, there are also mental health consequences of having a needle stick injury. Now, the detailed analysis, one, we looked at issues of HIV exposure. Out of the 1665 healthcare workers exposed, 66% of them had a baseline HIV test. And out of these, 11 or 1% were identified to be HIV positive. So previously they didn't know they were positive, and therefore now they were referred for care and treatment, while the remaining were eligible for PEP. But what is important is to see that almost 40% of the source patients, for those who were tested, were actually HIV infected, meaning you have a big risk. But this slide also brings out the information. How many of us as healthcare workers know our HIV status regularly? Because you can see sometimes you are getting your first diagnosis after a traumatic event. Looking at issues of hepatitis B, it was sad to note that only 20% of those people who got a needle stick injury had actually completed a hepatitis B vaccination series. And again, more importantly, is that at baseline, 3.4% of the healthcare workers were already hepatitis B infected, maybe slightly higher than the national prevalence. But also again, looking at 37% of the source patients were HBV infected. Now you get into this situation where you have low hepatitis B vaccination status and very high source patient hepatitis B prevalence. So that's a double jeopardy. Now looking at the PEP cascade, of course, after the 1665, 11 were excluded. What is important is to see that out of the 1,600 that started PEP, only 20% completed due to various reasons. But apart from the completion of the PEP, it is important to have follow-up tests so that we know whether one seroconverted after the exposure. But now the follow-up was again very low. Only 11% of the healthcare workers had their 6 weeks test as the recommendations that time. Only 8% reached 3 months and 6% reached 6 months of follow-up. Now, of the 11% that had a 6 weeks follow-up of a HIV test, one actually turned out to be positive and is suspected to have been a seroconversion. What interventions have we supported in terms of this? One is trying to simplify the issue of reporting by making it anonymous through a mobile application, the C4C, which I know Dr. Kade will be presenting after me. There's a new partnership that tries to address issues of cannulation and infusion safety, because as I showed, it was one of the leading causes of needle stick injuries. This partnership is being rolled out in 9 counties in the country, and it is called KINGA. It was launched by the Cabinet Administrative Secretary on Tuesday. There is also a campaign to vaccinate healthcare workers for hepatitis B in the 9 counties I've mentioned, and also policies including the National Injection Safety Policy of 2018. So trying really to improve the safety of healthcare workers. And what I want to say is, as I conclude, is that when the healthcare worker is not safe, the patient is not safe either. There are multiple studies, and I have provided references where infected healthcare workers transmitted bloodborne pathogens to patients unknowingly and not intentionally. And these are especially associated with what is called exposure-prone procedures. These are like major invasive procedures. Blind procedures is sometimes you are doing a major operation and you are trying to feel the tip of the gadget you are using and you get a prick. Repair of major trauma, some of the dental procedures, and you can read many articles describing to that. And we know that that is made worse when, for example, there is lack of PPE, or for example, there is no double gloving in aggressive procedures like in orthopedic, and one glove tears off, skin breaches. But occasionally we have heard of deliberate transmission, like the case that was reported last year in Pakistan, where a HIV-infected doctor deliberately infected a lot of patients. So when a healthcare worker is not safe, patients are not safe either. In conclusion, needle stick injuries are still prevalent in Kenya, and they expose healthcare workers to potentially chronic and severe bloodborne pathogens. It is important to put mitigation measures in place, starting from policy, safer devices which are safety engineered, training and capacity building, ensuring everyone is hepatitis B vaccinated, and in case of injury, then prompt and appropriate first aid, post-exposure prophylaxis, and reporting and follow-up mechanism that can even address those eventually who seroconvert or get an occupationally acquired disease. I have provided references, and thank you very much for this opportunity. I acknowledge the Ministry of Health, CDC, mHealth, BD, and all other stakeholders. Thank you.
Thank you very much, Dr. Kimani, for that wonderful presentation. We appreciate the work that you've done, and we've learned quite a lot, especially about the needle stick injuries from your presentation. I'm seeing a few comments from the participants in the Q&A section, and this one's probably I'll ask Dr. Irungu much later on to address them. But there's a comment from Patricia, and she's saying, in view of the low reporting and the fact that nurses are constantly using sharps, could it be that nurses are so used to pricks that they don't bother reporting? Thank you for that comment, Patricia. Kindly put your feedback, thoughts, suggestions about health worker safety in the Q&A section, and the panelists will be able to see them. Our next presenter is Dr. Kathy Mwangi. Dr. Kathy Mwangi is the founder and CEO of mHealth Kenya. mHealth Kenya it's an enterprise application software that deals with helps delivery of quality healthcare. So I'll let Dr. Kathy Mwangi tell us more about mHealth Kenya and Care for Carers, which will be the topic for today. Karibu, Dr. Kathy Mwangi.
Good morning, thank you. I wanted to show my face before I share my screen, and I'll go ahead and share my screen. I would like to present this. Let me know once you see it.
Yes, we can see it.
Great. All right, so my name is Kathy Mwangi. I work for mHealth Kenya, and mHealth Kenya is a tech company that utilizes mHealth innovations to impact care and treatment. We remain keen and intentional in continuing to support all efforts towards ensuring healthcare worker safety through innovations that leverage on technology. We try to develop systems that will build on existing achievements and innovate solutions that complement other systems and processes. And because we are just a tech company, we leverage on the experience of the Ministry of Health, the doctors, the nurses, and other implementing partners who have the expertise to make us develop relevant solutions. You know, a healthy environment for patients is important, but even more so for healthcare workers. You know, so hospitals should really be a place of healing and safety for providers and patients and guests. And a safe and healthy work environment promotes work productivity And, you know, healthcare workers are known to be at a higher risk. And just to follow up on what Dr. Kimani said, you know, they're higher risk at infections from bloodborne pathogens. And we've also seen the experiences with COVID-19. I like to share this. I've shared this many times. This was a nurse that was followed up in one research. And this just shows how the kind of movements healthcare workers have to go through in a single day. And they are human, so they are constantly adapting to demanding, you know, complex and fragmented systems, different solutions, you know, and then COVID happens. So you can imagine having to worry about the healthcare of everybody else, and it happens that most of the time they'll also forget what they need to do to protect themselves, and so it's an illustration that I like to use, that just to show how complex the systems are for our healthcare workers. And so what can we do then to improve, and how can we use technology? So technology in the workplace is not just for increasing worker productivity. You know, we use solutions to improve work, you know, productivity, to make things easier, but it has also been used to improve workplace safety and provide better working conditions over time. And, you know, we know, and we've also listened to Dr. Kimani, who says, you know, the study that was done showing workplace injuries and exposures that are still frequent, and hospitals together with employers need to take responsibility to ensure employees are safe at work, and those who get injured or exposed are linked to care in an empathetic way. So, you know, you can use technology to ensure employee safety and be able to comply with OSHA. It's also important to reduce exposures, incidents, and avail data. And most importantly, you had Dr. Kimani give analytics of that study. It took, you know, several officers to go to the facilities to look at the PEP registers to figure out how many nurses are exposed, how many doctors are exposed, how many actually report PEP, how many do not. With the use of technology, you can have that information real time. And that is how Care for the Carer came to be. So through the national, you know, the support, obviously, like I said earlier, we are techies. So we can have the gaps, but how do we actually come up with a solution that works? So we worked very closely with the National AIDS and STI Control Program, and also in coordination with the Ministry of Health, the Directorate of Health Standards, Quality Assurance and Regulation, and also the Division of Healthcare Worker Safety. We came up with this innovation to support you know, the healthcare workers. We call it Care for the Carer, but simply you will hear people say C4C. And the platform offers a number of solutions. The healthcare workers can self-report exposures, you know, occupational exposures incidents for both HIV. And we recently added a module to report COVID-19, but I must say that this has not yet been implemented. It's been enhanced, C4C has been enhanced, but we haven't started implementing yet. It has a dynamic resource center that allows healthcare workers to access protocols on management of such exposures and reminders to adhere to guidelines and many other health-related materials. It has a platform that allows healthcare workers to communicate amongst themselves, institutions, and for the improved service delivery. So we have a communication platform. A hospital that has their healthcare workers registered on the platform can send blast messages if there is information that they need to send quickly to healthcare workers. You can even segregate the cadres if you want to communicate to specific cadres, and I'll allude to that a little bit later. And healthcare workers can actually track their related immunizations and receive reminders of pending immunizations through a personalized diary. So even when you report an exposure to HIV, everything after that, any communication after that is completely secure and private, and it's personalized to the healthcare worker. Then the communication platform is what's open to either to the facility, to the county, to institutions, or at a national level. So if you want to send one message at a national level, you can send a message to all healthcare workers on the platform. Obviously, I would like to mention about the functionalities of the platform. It allows for easy, fast, cost-effective means of disseminating information through broadcast messaging. The system is fully owned and housed at the Ministry of Health, and we would like to thank NASCOP for giving us custody and servers and security, and that's why where the system is housed. And the platform and data is secure and access is controlled. And we do this through collaboration with the Ministry of Health and the HIS department. Only aggregated data is used to identify gaps that exist, and no identifying information is available. There is a resource center. This has curated materials, guidelines, protocols, both general and specific to users, either by CADA, by facility, by partner, county, and nationally. And it links to e-learning platforms and training platforms. The two that we have currently are a link to University of San Francisco, who are partnering with University of Nairobi to train healthcare workers, and NASCOP. And just to show that the platform is agile enough to add more e-learning platforms for different partners. If you have something and you would want that accessed by different healthcare workers, and again by CADA. It also has an immunization tracking module that allows to keep record of occupational related immunizations administered to healthcare workers. Again, we saw how crazy life can be for a healthcare worker. So you know how often they may forget to go for follow-ups, whether it's a test, whether it's pick up their PEP regiment, whether it's go for your next immunization. So this allows for tracking and being able to get reminders for any upcoming immunizations, and allow for proper planning by individuals and management. It has the module for exposure reporting. This allows for healthcare workers to confidentially report occupational exposures, and thus, and this is private and secure, again, just to reduce the associated stigma. And the documentation of such exposures is also very confidential and access controlled. In case of exposure for HIV/AIDS, the healthcare workers will receive alerts and reminders of PEP regimen, or when they're supposed to go for their next test. And this has also, like I said earlier, has also been recently enhanced to report COVID-19 exposures. Then there are materials that we have added into the platform in collaboration with the Ministry of Health. Any information that was felt needed for the healthcare workers while they're out in the fields, to just help them on the different protocols that are coming up. And it allows healthcare workers, wherever they are, to avail those resources and guidelines. And it also allows access to the ECHO trainings that NASCOP does. So we are able to link them to the trainings that have already happened. Current implementation and still ongoing, we have close to 11,000 healthcare workers enrolled on the platform. We are in over 778 facilities. And I must commend Kenyatta National Hospital. Right now, they have the largest number of healthcare workers registered on the platform and are actively using it. We look forward to continued collaborations together with the Ministry of Health, the national and county governments, in enrolling more healthcare workers to enrich the platform maximally. Just to show a little bit on the numbers, currently 10,061, and I think that number is still growing. Healthcare workers are registered. We are in all counties, but obviously, some facilities, not too many in some counties. We've currently working with 15 partners. This could be implementing partners or counties, but currently with 15 partners. Dr. Kimani mentioned about the reporting of exposures and sometimes how low the rate of reporting is. You can imagine we have this over 10,000 healthcare workers, but right now we've only had 70 exposures reported. And these are specific to HIV exposures. So we need to, see how we can encourage healthcare workers to continue reporting exposures so that we can help figure out how we can better manage or train the different healthcare workers and cadres on infection prevention and control. And we have the broadcast messaging platform that helps to send broadcast messages. And I think we have more than 65 currently. The last I checked, we had 65 broadcast messages. We do have a web portal that allows you to pull data, again, aggregate data. And this just shows, like, if you wanted to see the number of healthcare workers enrolled, you are able to find out from, cleaners, doctors, clinical officers, lab technologists. And what we do is work closely with the Ministry of Health. You can see this here, other, shows a big number. So we need to look at that and see how we can be a little bit more specific. If there is a cadre within here that's growing and needs to be separated so that we are reporting individually. Again, the platform is agile, so we can continue tweaking it so that we can better report in the future. I would like to congratulate all our healthcare workers for continuously working selflessly and tirelessly in the provision of care before this pandemic and ensuring that care hasn't stopped despite the pandemic. We know that there's a lot going on. We know what kind of challenges you have to go through, but from where we are sitting, we still appreciate you, we acknowledge you, and we pray that you continue doing what you do, taking care of us despite all the craziness going on right now. I must acknowledge quite a number of people. I'll do it quick. The Ministry of Health, NASCOP, the different divisions and departments, the Directorate of Health Standards, Quality Assurance and Infection and Prevention of Control. A lot of the things that we have done, and in being able to perfect the technology, we have had to consult with all these different departments. And we have been supported through a cooperative agreement with CDC. And so we would like to acknowledge PEPFAR and the Center of Disease Control for allowing us and for the cooperative agreement, and the county governments that we are working with. But again, I must also acknowledge Kenyatta National Hospital. They have tirelessly continued to encourage their healthcare workers to register on the platform and constantly communicating with them. They have been truly our biggest cheerleader, and we are working very closely with we want to work very closely with as many hospitals in the country as possible. Thank you very much. And again, congratulations to our healthcare workers. Keep up the good work. We are here with you and we continue praying for you. Thank you, and over.
Thank you so much, Dr. Kathy, for that elaborate presentation on the C4C. And I believe all the healthcare workers, I'm seeing out of over 120,000 healthcare workers that we have, only 10,000 are registered. So I think that's a need for a call to all healthcare workers to be able to register with the C4C and be able to share experiences and report any injuries that they go through. Thank you so much. Next online, we'll have our keynote speech for today, which will come from Mr. Gamaliel Omondi from the Ministry of Health, from the Occupational Safety and Health Department. Welcome, Mr. Gamaliel. Gamaliel Omondi, I can see you.
Yes, please. Can you hear me now?
Yes, karibu sana.
Asante sana. Thank you very much. I think a lot has been said, and they all revolve around occupational health and safety. Some of it has captured well the speech that I have, but still I will have to deliver the speech to grace the occasion. So the Director General for Health, Dr. Patrick Amot, the CEO mHealth, Dr. Kathy Mwangi, the CDC Kenya Country Office Representative, Dr. Kimani, the MTAPS MSH Representative, Dr. Kusundinda, Kenyatta National Hospital Representative, Dr. Kutoi, Representative of the Directorate of Health Standards, Quality Assurance and Regulations, Dr. Amos Oyoko, the Head Division of Patient and Health Worker Safety, Dr. Irungu, distinguished guests, ladies and gentlemen. Today, 17th September, we commemorate the World Patient Safety and Health Workers Memorial Day. This occasion presents us with the opportunity to reflect the past and how our actions can prevent future work-related deaths, injuries, and illnesses. It is a day to remember our health workers who have died specifically from workplace-related COVID-19 illness and generally other workplace injuries and illnesses. In my view, the day should focus more on awareness raising, and indeed it has done that, not only pandemic infections, but also other occupational related illnesses and risks in the health sector. By raising awareness of workers' health and safety and taking action, we can help prevent further injuries and deaths among health workers and save lives of our patients and clients who come to healthcare facilities to seek for treatment and wellness services. Ladies and gentlemen, over the course of the past 2 decades, the world has witnessed a number of infectious disease outbreaks which have shown a high speed of transmission. Currently, concern is growing over the continuing rise in COVID-19 infections in some parts of the world, and Kenya is included, and the ability to sustain declining rates in others. Governments, employers, workers, and the organizations face enormous challenges as they try to combat the COVID-19 pandemic and protect safety and health at work. Beyond the immediate crisis, there are also concerns about resuming activity in a manner that sustains progress made in suppressing transmission. We need to explore measures to prevent and control the risk of infection, psychosocial risks, economic and other work-related safety and health risks associated with this pandemic. COVID-19 has brought with it a need for health workers to adapt to rapidly changing workplace practices. Under the health and safety laws, employers have a duty of care for the health and safety of their workers and others in the workplace. This duty extends to managing the risk of exposure to COVID-19. Our health facilities can reduce health workers and patients' risk of exposure to COVID-19 by ensuring proper hygiene and cleanliness within our institutions, implementing physical distancing, and most importantly, using personal protective equipment as appropriate. How then is the world of work affected in this era of COVID-19 pandemic? The health workers are particularly vulnerable during a pandemic as they already face high occupational safety and health risks and lack of sufficient protection. Working in the absence of protection, such as compensatory benefits, these workers may need to make a choice between health and income, which comes at a risk to both their health and the health of the patient. Pandemics can also have a disproportionate economic impact on certain segments of the population, which can worsen inequality, affecting mostly some groups of workers, such as workers with underlying health conditions, older workers who may face higher risk of developing serious health issues and may suffer from economic vulnerabilities. Recent experiences with the severe acute respiratory syndrome, SARS, influenza, H1N1, and Ebola virus outbreaks have highlighted the importance of focusing on workplaces not only to identify at-risk populations, but also to understand mechanisms of disease propagation and to implement successful control and prevention measures. Workplaces are effective platforms where employers and workers together can disseminate information and sensitize on occupational health and safety, including for prevention and protection measures to reduce the spread of infectious diseases. Ladies and gentlemen, how can we ensure safety and health at work during a pandemic? By having a comprehensive emergency preparedness plan in the workplace, crafted to address health crises and pandemics, workplaces may be better prepared to develop a quick, coordinated, and effective response while adapting the measures to the specific emergency that the sector is facing. A continuous monitoring of occupational health and safety conditions and appropriate risk assessment is required to ensure that control measures related to the risk of infections are adapted to the specific evolving processes, conditions of work, and characteristics of the workforce during the critical period of infection and afterwards, so that recurrences may be prevented. How do we ensure safety and health at work? During a pandemic, infectious agents vary significantly in severity, lethality, modality of transmission, diagnostics, treatment, and management. A number of provisions in the International Labour Convention number 155 and its recommendation offer prevention and protection measures to mitigate the negative safety and health effects of pandemics such as COVID-19 in the world of work. Following are some of these provisions. The employers are required to ensure, so far as is reasonably practicable, that the workplaces, machinery, equipment, and processes under their control are safe and without risk to health, and that the chemical, physical, and biological substances and agents under their control are without risk to health when the appropriate measures of protection are taken. The employers are also required to provide, where necessary, adequate protective clothing and protective equipment to prevent, so far as is reasonably practicable, risk of accidents or of adverse effects on health. Such protective clothing and equipment should be provided without any cost to the worker. Employers should ensure that workers and their representatives are consulted, informed, and trained on occupational health and safety associated with their work. The workers and their representatives have the right to receive adequate information and training on occupational health and safety. They should also be enabled to inquire into and to be consulted by the employer on all aspects of occupational health and safety associated with their work. Additionally, workers have the right to remove themselves from a work situation which they have reasonable justification to believe presents an imminent and serious danger to their life or health without undue consequences. In such cases, workers should report these situations to their immediate supervisors. Until the employer has taken remedial action, if necessary, the employer cannot require workers to return to a work situation where there is continuing imminent and serious danger to life or health. Workers and their representatives should cooperate with the employer in the field of occupational health and safety. These should include taking reasonable care for their own safety and that of other persons who may be affected by their acts or omissions at work, complying with instructions given to their own safety and health and those of others, using safety devices and protective equipment correctly and not rendering them inoperable, reporting forthwith to their immediate supervisor any situation which they have reason to believe could present a hazard and which they cannot themselves correct, reporting any accident or injury to health which arises in the course of or in connection with work. All these measures that are given arising from the International Labour Agreement culminate into occupational health and safety management system. And arising from COVID-19 scenarios, it is important, therefore, to begin to think of how we can integrate emergency preparedness into occupational health and safety management systems. In the past, the occupational health and safety management system approach has been introduced in both industrialized and developing countries. Its application varies from legal requirements calling for its adoption at the workplace level to voluntary adoption. Experience shows that an occupational health and safety management system is a logical and useful tool for the continual improvement of occupational health and safety performance at the organizational level. The ILO guidelines on occupational safety and health management systems advocate that appropriate arrangements should be made for the establishment of occupational health and safety management systems, which should contain the following key elements. One is the policy, the organizing, planning, and implementation, evaluation, and action for improvement. The OSH management system approach ensures that the implementation of preventive and protective measures is carried out in an efficient and coherent manner. Pertinent policies are supposed to be established. Commitments are also made to implement the policies that are established. All the workplace elements should be assessed for hazards and risks. Management and workers are supposed to be involved in the process at their level of responsibility. Therefore, in establishing measures on risk prevention and control, the management system should also include clear procedures on emergency preparedness, planning responses for different scenarios, including a moderate outbreak or a severe pandemic. These procedures should be established in cooperation with external emergency services and other bodies where applicable, ensuring that the necessary information, internal communication, and coordination are provided to protect all health workers and patients in the event of an emergency. In the context of COVID-19, different types of measures can be implemented to reduce the risk of infections among healthcare and emergency workers. And indeed, the ministry has, in collaboration with partners, has tried to implement the measures. Number one is environmental and engineering controls aimed at reducing the spread of pathogens and the contamination of surfaces and objects. They include providing adequate space to allow physical distance between patients and healthcare workers, and ensuring the availability of well-ventilated isolation rooms for patients with suspected or confirmed COVID-19. Number two, administrative measures aiming to prevent risky behavior. These include adequate resources for infection prevention and control measures, such as appropriate infrastructure, the development of clear IPC policies, facilitated access to laboratory testing, appropriate triage and placement of patients, adequate staff to patient ratios, and training of staff. Another administrative measure that should be implemented relates to the health monitoring and surveillance of workers at risk, which I heard Dr. Kimani mention very well. And this is done in order to detect any unfavorable health effects of occupational hazards at an early stage when it is easier to treat the disease. For example, by monitoring workers for fever or other early symptoms of infectious disease. Arrangements must be made to ensure that any exposed person can easily report any symptoms to a supervisor, who in turn will need to notify a medical officer. When we talk of appropriate PPE, this involves selecting proper PPE and being trained on how to put on, remove, and dispose of it. WHO and the Ministry of Health have equally developed guidelines on the rights, roles, and responsibilities of health workers during the COVID-19 outbreak. And this also includes guidelines on donning and doffing of PPEs so that appropriateness is ensured. Off the cuff, I think there have been many complaints about inferior quality of PPEs. There is also need to establish a system of quality assurance for the PPEs that we use, and this should be encouraged to be done frequently and routinely. On laboratory personnel, the use of bacteria, viruses, blood, tissue, and or body fluids in the laboratory may cause infection. The WHO Laboratory Biosafety Manual provides practical guidance on techniques and measures for use in laboratories at all levels to prevent infection. We are all called upon to observe these guidelines and manuals. In addition, specific guidance on COVID-19 has also been developed, including recommendations addressing minimal essential working conditions associated with specific manipulations in laboratory settings. Death care workers. The human remains may pose health risks in some cases of infectious diseases. Although for COVID-19, now science has proved that it is very limited, but still workers involved in the management of dead bodies, including mortuary services, funerals, autopsies, or burials may be at risk of acquiring infection. including in some circumstances COVID-19, and therefore they are called upon to take proper precautions by practicing good hand hygiene, PPE, proper ventilation of work areas, and cleaning of instruments. Ladies and gentlemen, allow me to address myself to what has been done as a country in the pre-COVID-19 and what is planned for post-COVID-19 pandemic. Occupational risk assessment exercise was done in 100 health facilities across the country. This was supported by an organization called IntraHealth Kenya. And the results of the risk assessment painted a very gloomy picture, leading to development of national occupational safety and health guidelines for the health sector in 2014. That specific guideline is found online, and I would want to encourage all of us to access it, because the guideline explains every other thing that has been the subject of discussion for today. Then we further developed occupational safety and health training curriculum and manual for health workers to guide short courses and orientation in the health sector. And this was done by MSH in support, with support from CDC. The ministry also, in collaboration with the CDC through AFNET, conducted training of health workers in 10 pilot health facilities for implementation of the guidelines. The facilities that were selected for pilot included Kericho, Kisumu, Kakamega, Machakos, Kajiado, Nyeri, Mwingi, Mathare, and Kijabe Mission Hospital, which was used as a case study for private or mission health facilities. All the health facilities developed their workplace health and safety policy as a commitment to the implementation of the guidelines. And each health facility also established and trained health and safety committees in compliance with the requirements of the Occupational Safety and Health Act of 2007. Within the period of onset of COVID-19, the guidelines have been developed and protocols. Some of them have been domesticated, and a lot of capacity building with support from MSH, MTAPS, and Association of Kenya Medical Laboratory organizations were sensitized, trained. Over 50 laboratory staff were trained on occupational health and safety in the context of COVID-19 through virtual platform. Again, the MTAPS MSH supported another training of 100 nursing staff on occupational health and safety in the context of COVID-19, which was organized through the Nursing Association of Kenya. With support from AMREF and the Department of Environmental Health, about 100 public health officers have been sensitized on occupational health and safety in the context of COVID-19 through virtual platform. The ministry is also working closely with the Directorate of Occupational Safety and Health in the Ministry of Labor and Social Protection to oversee the operationalization of the Occupational Disease Fund. Currently, we are exploring a network of collaboration with Directorate of Occupational Safety and Health and National Environment Management Agency to undertake statutory risk assessment and audits of all our health facilities that have been used or were otherwise used as isolation and quarantine centers. Ladies and gentlemen, multi-sectoral actions in the context of COVID-19 included support to other sectors in coming up with guidelines for reopening of the economy. We have supported the Ministry of Transport and Infrastructure to develop air, rail, and road transport guidelines and protocols. The Ministry of Sports, Gender and Heritage developed guidelines for resumption of sporting activities and guidelines for reopening of recreational places, the Kenya Museum. Alongside this, we have also reviewed guidelines internally for disposal of the dead in the context of COVID-19, and externally, we have reviewed guidelines for opening of the gaming activities and the private sector protocols on the reopening of the economy. Going forward, therefore, we have planned to link occupational health services to primary health care and the rest of the health system. We also intend to develop advisories for addressing the specific health needs of workers in line with safety precautions at workplace, at primary healthcare level, and the rest of the healthcare system. We would want to stimulate national efforts to build human resource capacities for workers' health, both primary care and occupational health specialists, so as to reduce diseases emanating from occupational exposures. Only about 10% of the public health facilities are compliant with the Occupational Safety and Health Act. So we intend to scale up to 50% in the next 2 years to ensure that they have functional safety and health committees. Going forward, we are thinking of expanding to have a national program on occupational health of health workers that will provide policy framework for actions to protect health, safety, and well-being of workers in the health sector. This program will facilitate the regulatory compliance of facilities in the health sector with the national occupational safety and health laws and regulations, bearing in mind the specific working conditions and occupational hazards in the sector. This will aim at providing decent work, healthy and safe work environment for all health workers, thereby improving productivity and job satisfaction of health workers and their retention. Such program will also contribute to improving the quality of care and patient safety. By strengthening the protection of health and safety of health workers and responders, such program would increase the resilience of health services in the face of outbreaks and public health emergencies. Ladies and gentlemen, as I wind up, I would want to end with a quote from the Director General of the WHO, who said that the COVID-19 pandemic has heightened the urgent need for strong national programs to protect the health and safety of health workers, medical professionals, emergency responders, and the many other workers risking their lives on behalf of the entire world. And thank you very much. That is the end of the speech.
Thank you so much, Mr. Gamaliel Omondi, for that elaborate speech, which has really emphasized on issues surrounding occupational safety and health, which are key in as far as health worker safety is concerned. And I believe a policy on occupational safety and health is needed so that we can be able to address all the issues surrounding the occupational health and safety. At this point, in as far as the agenda is concerned, we were meant to have our Director General of Health, Dr. Patrick Amoth, to make his speech, but unfortunately, he's held up in another session with the CS. And most probably he'll be making his speech during the COVID-19 presser, where we also expect to have a statement from the CS. So on that note, I would wish to spend this time that was scheduled for Dr. Amoth to have responses to some questions which have been asked. And there are quite a several questions, but I'll just pick a few of them and direct them to the respective respondents or panelists. And first of all, I read out the questions, then I'll give the panelists an opportunity to respond. I'll start with the questions directed to Dr. Kimani. Number one, from Christina Tieno. Could low exposure to needle pricks to nurses, that is which contributed to their low infection rate, be due to them being more careful when carrying on patient procedures? Then the second question is that could it be that injection safety trainings concentrate on nurses only and not on other cadres, hence contributing to their low exposure? The third question to Dr. Kimani is how many times can we go for testing after exposure to assure yourself that there's no seroconversion? So those are the questions for Dr. Kimani. The next question will go to Dr. Kathy Mwangi from an anonymous attendee who said, we had an Android application whereby health workers report such incidences, NCI, for easy follow-ups. I think it cannot be launched in all health facilities, question mark. Maybe it can help. So I presume the question will be understood. Then we'll go to questions to Mr. Gamaliel Omondi. We have two questions. Number one from Pauline Chebon. How do we maintain proper hygiene when most of the facilities we work in are dilapidated, old buildings with wanting ventilation, lighting, etc.? The second question to Mr. Gamaliel. So maybe we can have those responses to those questions before we can proceed. Thank you. Maybe we can start with Dr. Kimani, then followed up by Dr. Kathy.
Yeah, so thank you very much, Dr. Irongo, for those questions. I want to combine the question by Christine Otieno and Susan, and a comment that was made by Dr. Patricia Oluoch. This is in relation to needle stick injuries among nurses and why are they apparently fewer. I think there could be several factors related to this. I think one has already been alluded by Susan, who says that injection safety training may have been more prioritized among the nurses. I remember between 2005 and 2009, there was a lot of injection safety training that was being led by John Snow Incorporated, JSI. And when we looked at the participation of even those trainings, most of the time it's true that nurses would attend. Sometimes the doctors and clinical officers would probably brush off the training about injection safety, and therefore the nurses would have been more. But there's a second issue related to the procedures that they carry out, probably less risky procedures, the IM subcutaneous injections for FP and therapeutic. When you look at the cadres of the doctors and the clinical officers, they are the ones that are called upon when, for example, the line is more complicated, they need to fix the line, the blood collection is complicated. So it is more likely that those ones get the procedures that are more complicated than the ones that are likely to cause a needle stick injury. But I also note the comment by Patricia that there could also be an issue of probably complacence whereby the reporting is lower. She puts it that could it be they have gotten many pricks and sometimes they don't report? I may not confirm about that, but it could be a possibility. Coming to the question by Ali Hussein about how many times one needs to be followed up. The NASCOP guidelines on post-exposure prophylaxis for healthcare workers currently has two timings. You need to have a follow-up, of course, a baseline test to confirm that you are not HIV positive. And I also want to respond to a question that was put by Lilian Otieno, who asked that if the test is negative, do you actually need a follow-up? Remember that most of the HIV and hepatitis B tests that we have now are antibody-based, and there is the window period that is there. So in countries like ours where HIV prevalence is relatively high, a negative HIV test or hepatitis should not be a reason not to take PEP, because someone could be in the window period and the viral load is actually very high during that time. After the baseline test and you start on PEP, the next test is at 4 weeks and the last one at 12 weeks. Initially, it used to be 6 weeks, 12 weeks, and 6 months, but the current guidelines is at 4 weeks and 12 weeks. Thank you.
Thank you so much, Dr. Kimani. Then we can have Dr. Kathy respond to the question that was asked about an Android app. Welcome.
Thank you. I hope I understood the question, but if I want to believe that maybe they are referring to a previous Android app that was developed that was helping in reporting needle stick injuries. We had a previous app that was called MPEP, and that was rolled out before 2015. And Care for the Carer is actually the improved version, which we did. And the component of reporting exposures is actually part of the module that was previously rolled out as MPEP. So the Care for the Carer has an Android version, but it also allows people who have mulikamwizis, to be able to report. We do have a link that we have also shared that is web-based, where you can download and actually register yourself. But for the most part, the most encouraged version is the Android version, and we are about to launch the iOS version for people with iPhones. But we do have the component for needle stick injury reporting on the Android app. I hope I've responded to his or her question. Thank you.
Thank you so much, Dr. Kathy. Then I have two questions to Mr. Gamali Romondi. Number one from our anonymous attendee. In the context of infection control, is it okay for guardrails in busy hospitals to be made of wood? Then the other question, what is MOH doing to enhance access to hepatitis B vaccine, hepatitis B virus vaccination for healthcare workers? Welcome, Mr. Omondi.
Thank you very much. Can you repeat the first question, the guardrails?
In the context, in the context of infection control, is it okay for guardrails in busy hospitals to be made of wood?
The answer is outrightly no. We may encourage metal surfaces for ease of cleaning and disinfection.
The second question was, what is MOH doing to enhance access to hepatitis B virus vaccination for healthcare workers?
Well, for hepatitis B vaccination, I think this is a long history. I remember around 2012 going to 2014, we had a lot of vaccines in National Public Health Laboratory services. And health workers were being called upon to come forward and get these jabs. But I think following up, the routine of getting the jab became a question. Most of them fell out after receiving the first and the second dose. So that led to some little drop in the efforts that were being made. But towards the end of last year, we picked it up again, and working with NASCOP, we were trying to develop immunization cards that will be issued to health workers. What I want to encourage health workers is that when it comes up again, please take up the service, because it is your safety. It is you who is protecting himself or herself. Whether it is so painful as what, but let us run it through the whole course.
Thank you so much, Mr. Gamali Romondi, and thank you everyone. On the agenda, the next session was our closing remarks from Dr. Ivan Wesangula, who is also not able to join in at this point. So I'll do the closing remarks on her behalf. So on behalf of the Ministry of Health and the Directorate of Health Standards, Quality Assurance and Regulations, and our Division of Patient and Health Worker Safety, we wish to thank, first of all, the Cabinet Secretary of Health, the WHO representatives, the Chief Administrative Secretaries, Ministry of Health, the Director General, the director of our directorate, the head of the Department of Health Standards and Quality Assurance, for the support that they have given us as we prepared for this day. As we know, it was we had the World Patient Safety Week, and we had several activities which were going on. I also wish to thank the staff of the Division of Health Workers who have worked tirelessly and burning the midnight oil to make sure that this day became a success. I cannot forget all our partners from the Kenyatta National Hospital, University of Nairobi, USAID, MTAPS, mHealth, PharmAccess, and CDC for both support, especially when it came to commodities that we have used to make this day a success. To all the panelists, without you, this day would not have been a success, and I wish to thank all of you. I also wish to thank all the committee members who have been there during the preparation phase to mark this day. And finally, to all the participants who reached up to over 600, which is very commendable. We would have wished to have this meeting in a physical way, but because of the current situation, we have to do it virtually, but I think that the participation was very great. Thank you so much, and I want to hand back to Dr. Kalondu for any other remarks. Dr. Kalondu, karibu.
Thank you, Dr. Irungu. Thank you. I think you've already done the vote of thanks. So I'd just like to end this session by saying that it has been a pleasure being with all of you today. I'd like to thank all our participants who were patient with us and who found time to attend this session. And just like Dr. Irungu has said, we'd like to also thank the panelists for finding time, always heeding our call and being there for us. Asanteni sana. And as we continue marking the World Patient Safety Day, I'd urge you, if you're a healthcare facility, if you're listening from a management position, kindly put measures to protect your staff, your healthcare workers, not just the PPE, but also simple things like the immunization, hepatitis B vaccine. We're seeing quite a bit of remarks in the Q&A section about that, about hepatitis B. Somebody is also asking about policies that are put in place and monitoring of needle prick injuries in clinical areas. Those are real things that we can start small. So let's start small. Let's start doing something. Next year, as we have the next World Patient Safety Day, let's look at the milestones that we've achieved throughout the course of the year. And thank you very much. And I'd like to thank the KNH research team for always availing themselves and finding time to host us in their platform. Asante sana. And thank you to the chief guest, Mr. Gamaliel Omondi, in absentia, to Dr. Patrick Amoth and Dr. Evelyn Wesangla for actively participating in the discussions and in the meetings that we had. A few of our partners were not able to make it. PSK, Dr. Daniela Monene, and CAPI. We'd like to thank you all for being there and supporting us every single year that we call up and call out on you. Asanteni sana. And from KNH, maybe Dr. Oktoi can bid us by as we end the session.
Thank you very much. On behalf of the KNH management, that is our CEO and board, and my director, clinical services, who coordinates the clinical activities within KNH. I think we are honored that we got opportunity to host and to give a voice. And these are efforts that we can all win together and we can learn together so that the mistake your neighbor has done will not happen to you. The strength that your neighbor has, you will learn and adopt them. So we and ask for more indulgence that this is awareness and campaign. Dr. Kalondu, we will ask for more opportunity to interact on the subject patient safety so that we look at our milestones. So thank you. It is only the second World Patient Safety Day. When you do the third one, we will have more structured activities. We'll measure real milestones and we will learn together the collaborative effort from multiple sectors. Our mother, we are grateful that you give us the opportunity to serve and do it this way. Thank you.
Thank you very much. And maybe just one last comment from Dr. Kathy Mwangi. How can members enroll on the C4C as we end? And Dr. Kathy Mwangi, you're closing the session for us. How can the participants who are not aware and have just learned about it, how can they join C4C? Sorry, Dr. Mike. Yes.
Sorry. You can go into Google Play Store and search for C4C, which stands for care for the carer. And I think on the chat, I've also shared that link. There was someone who had asked a Google link. And maybe when I also share my presentation to those who will have access to it, I'll also share the link. And feel free to contact anyone within mHealth Kenya to support any facility or county that is willing to take up the platform. We will support you. We'll work with you to make sure all the healthcare workers are trained on the platform, even though virtually. Over. Thank you.
Thank you. So go to Google Play Store, as Dr. Kathy Mwangi says, and download C4C. And from there, it's very easy to join. But in case you have any challenges, the contacts, mHealth contacts are on all platforms. If you Google them, you'll get their contacts and they'll be able to direct you how to join. Thank you very much, Dr. Daniel Kimani, for your informative presentation on needle stick injuries. We appreciate that. We don't take it for granted, and we hope to see more studies in future with regards to patient and staff safety. So I'd like to end this session. Asanteni sana. Have a good afternoon and bye. Thank you.